Hey guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and I followed through with my promise. We're doing part 2 of high-risk pregnancies. If you haven't watched part 1 already, that's fine. It doesn't go in any particular order, but just be sure to go back and watch part 1. Lots of great information for you. Before we get started, as always, I'm going to ask you to please support me and support this channel. You can do that by liking this video. You're going to love it. Go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already. And be sure to check out my website, nexusnursinginstitute.com. There you can sign up for Next Generation NCLEX review session, part 1 and part 2. Part 1, I teach you how to think critically. I teach you what the test writers are trying to pull from you with these questions. I teach you about prioritization. I teach you about delegation, critical thinking. In part 2, we actually go over NCLEX type of questions, rationales, important things that you need to know. If you're a current nursing student and you are struggling, you have to do really well on your next exam, I suggest you check out my audio lessons and see if I have one that covers whatever you're going to be testing on. I guarantee you this information that you need to know. Also, if you're a nursing student or you've graduated already, but you're studying for your boards and you just need that one-on-one attention, you can sign up for a one-on-one private tutoring session with me, or maybe you just want to pick my brain about something. Again, check out my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, Facebook, and of course, right here on YouTube. My handle is the same everywhere, Nexus Nursing. Now, without any further ado, let's get started. High-risk pregnancy, part 2. Which of the following is the priority nursing action in a patient suspected of having placenta previa? Here are the options. Perform a vaginal exam to assess the cervix, monitor the fetal heart rate and maternal vital signs, prepare the patient for an immediate C-section, administer a uterine stimulant to control bleeding. Very good. Monitor fetal heart rate and maternal vital signs. Guys, across the board, the rule of thumb is you go from least invasive to most invasive, right? How do you know that you have to do is prepare the patient for a C-section when you have not even assessed the patient to see what's wrong? Look at the question. Which of the following is the priority nursing action the patient what? Suspected of having placenta previa. The first thing you're going to do is get information. How are you going to get information? By assessing your patient, assessing the fetus, getting information. That's what you're going to do. You're going to monitor the fetal heart rate and the maternal vital signs. You're going to assess the patient and you're going to assess the fetus. Now let's talk about this placenta previa. This is where the placenta is implanted in the lower portion of the uterine wall. It's the lower portion. It's either completely covering or partially covering the cervical os. All right. This put the patient at risk for what? Bleeding. God forbid we have any dilation going on. Look at the first option, perform a vaginal exam to assess the cervix. Are you crazy? Did I not just tell you that in this condition, the placenta is implanted in the lower portion of the uterus? Partially or completely covering the cervical os. So you're not going to be doing any vaginal exam. Matter of fact, you're going to teach that patient, guess what? No sexual intercourse for you. I'm so sorry. Okay. Next, prepare the patient for immediate C-section. Maybe that patient absolutely may have to have a C-section. We don't know yet. We haven't even assessed that patient. We're not there yet. And last, I cannot believe 19 of you guys chose this as an answer, but I'm not going to yell. I'm going to remain calm. Administering a uterine stimulant. Want to know what a uterine stimulant's going to do? It's going to cause contractions. Now, just imagine this placenta that has implanted on the bottom near the cervix or even covering the cervix. Do you think that it would be a good idea to go ahead and stimulate that uterus, to go ahead and promote placental abruption, detachment of that placenta from the uterus. Do you think that would be a good idea? Are we looking to lose our license today? Absolutely not. That's not something we're going to do, right? So what we are going to do is assess our patient. Okay? All right. Next question. You're educating a pregnant patient diagnosed with placenta previa. What statement by the patient indicates a need for further teaching? Would it be, I should avoid sexual activity for the rest of my pregnancy? It's okay to travel by airplane at 36 weeks as long as I feel fine. I need to avoid heavy lifting and strenuous exercise, or I should notify my healthcare provider immediately if I experience any vaginal bleeding. What do you guys think? Very good. No, it's not okay to travel as long as you feel fine. Think about what's happening here. We have to be very, very careful with this type of patient. If they are less than 36, 37 weeks, we're going to monitor them. They're going to be on bed rest, and we're going to monitor them very closely. If they're 37 weeks or up, what are we going to do? Yeah, we're getting that baby out of there, right? Mom's going to have a C-section. So in no way, shape, or form, someone with placenta previa, we want them to do anything that can cause stress to the uterus, anything that can cause bleeding, none of that. So no, you can't go high, I was about to say high temperature, not temperature, high, what's the word I'm looking for? High elevations. That's not the word I'm looking for, but I can't think of it. You can't do that. You can't do anything that can cause complications. Thank you, altitude. Thank you, thank you, thank you, thank you. You can't go in high altitudes that can cause pressure. We don't want anything that can cause pressure to that area. So no strenuous exercise, no high altitudes, no sexual activity, no heavy lifting, none of that. You are going to be on bed rest. And once you hit around that 37th week and it's safer, guess what? You're going to get that C-section. All right, type in your answer. Your patient presents with sudden onset of severe abdominal pain, rigid uterus, and dark vaginal bleeding. Type in your answer. What should you suspect as a nurse? Type in your answer. Again, your patient presents to the emergency room with severe abdominal pain, a rigid uterus, and dark vaginal bleeding. What would you suspect? Very good. Placental abruption. Most of you guys got it right. Very, very good. Very, very good. So we're suspecting that that placenta has actually detached from the uterus. Okay. This is a medical emergency. Oh, can't see the question. Which of the following is a priority nursing intervention for placental abruption? Is it to administer tocolytic medication to stop the infusion, to stop the uterine contraction? Is it to perform a vaginal exam to assess for cervical dilation? Is it to initiate continuous fetal heart monitoring and assess maternal vital signs, or placing the patient in a supine position with the legs elevated? Very good. You're going to initiate continuous fetal heart monitoring and assess the maternal vital signs. Why? This patient is at risk for bleeding, hemorrhaging, shock, death. This is a medical emergency. Okay. The first choice, administer tocolytic. Oh my gosh. Again, again. The placenta has actually detached from the uterus. This patient is um already at risk, serious risk. This is not the patient that we want to go ahead and give them a tocolytic, because that patient's going to be going into the OR. They're going to be getting surgery. They're going to get C-section. Okay, they're not going to be giving birth vaginally, if we can help it. Perform a medical exam to assess for cervical dilation. Absolutely not. You are not doing a vaginal exam on this patient. Last, place the patient in supine position. No. So let's talk about this, guys. You placing them in a supine position, that's going to decrease oxygenation, perfusion to mom, because just think about it. With them lying down, the weight of that uterus against the vena cava, right? So what we are going to do is assess our patient. We're going to assess the patient. We're going to assess the fetus. All right, prioritize actions for a patient. Prioritize actions for a patient suspected of having a placental abruption. Here are our options. Oh, guys, I'm sorry. I'll go back to that. I'm sorry. But let's do this one first. Notify the healthcare provider, establish IV access with large bore catheter, administer oxygen via face mask, initiate continuous fetal heart monitoring. Let's do this one and I'll go back. I know. I was thinking of something else in my brain. I'm going to fix that. Okay. Wait a minute. Only 2 of you guys got this right? Okay. We're going to talk about this. Then we'll go back to the tocolytic because oh my gosh, guys, I had something else in my brain. So I got to go back and correct what I said to you on the last slide. But let's do this one first. Then I'm going to go back because you guys are absolutely right. I do apologize. But let's do this question first. Patient is suspected of having a placental abruption. Detachment of that placenta from the uterus. Patient is at risk for shock. They are at risk for, this is the biggest problem, right? So the first thing we're going to do always, guys, the nursing process, assess. You're going to make sure you assess your patient. You're going to assess the fetus. Great. I believe most of you guys got the first answer right. Here's where I think you guys messed up. The second thing you're going to do is establish IV access with a large bore needle. Now, I think most of you guys chose this next, administer oxygen. Why? Because it's been drilled in your brain, ABC, 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 which is correct. Who cares about the patient, about anything else if the patient's not breathing? That's absolutely true. But guys, this is where your critical thinking comes in. What's wrong with our patient? What's wrong with our patient is that they're at risk for bleeding out, because the placenta has detached from the uterus, right? Their problem is not oxygen. They've got oxygen. There's nothing in the question telling us that the patient doesn't have oxygen. The problem is that they're at risk for bleeding out. Bleeding out. So that's why we're going to go ahead and establish IV access with a large bore catheter, because that patient's going to get fluids hard and fast. We expect to probably most likely replace blood. We're going to be giving this patient blood products. We're going to be giving this patient medications. That's why the IV access comes before oxygenation. Now, if this was a question about a patient that had a condition where oxygen was going to be an issue, yes, oxygen would come first. But in this case, this oxygen that we're giving the patient is supplemental, because the problem doesn't even have to do with oxygen. It has to do with blood that's being lost. Now, because blood is being lost, I want you to think about it. What's in the blood? Vitamins, minerals, nutrients, and what? Oxygen. So because they're losing blood and oxygen is also found in the blood, the perfusion is going to go down. So yes, we're going to give them supplemental oxygen, but guys, that's not the primary concern, primary problem. What's causing the decrease in oxygen and decrease of what? Blood that the patient's losing out. That's why they're going to get the IV first. We're going to be giving them lots of fluids. We're going to be giving them blood. We're going to be giving them medications, all which needs to be established through an IV access, a line. Then, of course, we're going to give them the supplemental oxygen via face mask. And of course, last, we're going to notify the healthcare provider. And the reason that we're going to notify the healthcare provider is because what do we expect to happen? Surgery, patients going in the OR, right? They're going to get a C-section. Okay. You guys with me? Now let's go back to the last question, guys. I'm sorry. I was so confused. I'm sorry, but guess what? I'm human. Let's look at this question. Let me go back and read the question. Which of the following is for priority nursing intervention for a patient with placental abruption? So they are at risk for bleeding. I don't recall what exactly I said to you about tocolytic, but let me correct that because you guys are so right. I don't know what I was thinking. Tocolytic. So the answer said administer tocolytic to stop the uterine contractions. Here's the thing. When it comes to placental abruption, what's the biggest problem? Bleeding. Bleeding. How do we stop the bleeding? The contractions. The contractions are good. So I'm so sorry, guys. I was just going off on a tangent and I was so wrong. So please excuse me. Just rewind back to what I said before. And so that is why this is wrong. Okay, I'm so sorry. Guys, I'm human. Forgive me. But everything else I said about the screen is correct. Just that one portion. Okay. Sorry about that. You guys with me on the live? Okay, good. It's still no. It's still the correct answer. You're still going to initiate continuous fetal heart monitoring and assess maternal vital signs. That doesn't change. That is still the correct answer. I just had to correct that statement I made about the tocolytics. Absolutely. Here's how you guys have to think about it. When you're prioritizing, you have to think about what is going to kill your patient the fastest. But before you get to that, you have to get information. If in the question there's not enough information given to you for you to do something about it, you always going to assess. You're going to get some information. Very good. Okay. All right, moving on, guys. I'm sorry, I had to make that correction. Okay. Which would you expect to see in a patient diagnosed with DIC? DIC is disseminated intravascular coagulation because of placental abruption. So you have a patient that has DIC, but the DIC was caused by placental abruption. What would you expect to see in this type of patient? Would it be increased platelet count? Would it be prolonged clotting times? Would it be warm flesh skin or increased fibrinogen levels? I thought more of you guys would get this correct answer. So the correct answer is prolonged clotting times. It's taking longer for this patient to clot. They're at risk for bleeding. So let's talk about what's happening here. DIC is complex, but I'm going to just make it very simple for you guys to understand. So basically what's happening, guys, in DIC, there's an underlying cause, and whatever it is, because there's different reasons, whatever it is that's causing the DIC, all of the patient's clotting factors are being depleted. They're being used up. So the clotting factors are being used up, so the patient has all this bleeding going on, right? So they've got all this bleeding going on, and the body recognizes, hey, patient's bleeding. So it tries to make even more clotting factors because of the bleeding. So now you have all this external, internal bleeding that's happening, but then the patient starts to clot. But those clotting factors get used up again. So then they start to bleed. And then the body makes more clotting factors. Then they start to clot. But then all those clotting factors get depleted. So they start to bleed. So it's a horrible cycle. This is a pathological cycle of clotting, then bleeding, clotting, and bleeding. Primarily bleeding because those clotting factors are being depleted, right? So that patient who's having DIC, because they had a placental, guys, I don't co-host during Kahoots, because they had placental abruption, it makes sense that the patient's going to have increased clotting times. Why? They're bleeding all over the place and their clotting factors have been depleted. Look at the other options. Increase platelet count. I just told you in DIC, your clotting factors are depleted. What do platelets do? Help you clot. So how are you going to have increased platelet count? If anything, the platelet count would be what? Decreased. So that could be the answer. Warm, flushed skin. Think about it. What's happening, guys? The patient's clotting. Then they're bleeding. They've got all of this mass hemorrhage that's happening, and then they're clotting again. Okay, they're having circulation issues. What happens when you have circulation? The blood's not circulating the way that it's supposed to. You want to know what makes your blood nice and warm? I shouldn't have said that. I didn't mean blood. What makes your skin nice and warm? Blood flow. That's what, when you touch a patient's skin and it's warm, it's because of blood flow, right? When you see it's pink, it's because of blood flow. So this type of patient that's having circulation issues, first of all, the skin will be cool, not warm, because circulation's gone down. And the color is going to be pale because circulation has gone down. So that can't be the answer. And then last, increase fibrinogen levels. Well, no, because again, in DIC, all of your clotting factors are being depleted. So if anything, the fibrinogen levels in this type of patient is going to be what? Down. So the only correct answer here is increased clotting times. Why? Because the patient's bleeding. All right, medical management in all cases of DIC involves correction of the underlying cause. Is this true or is this false? Medical management of every single DIC case involves correction of the underlying cause. True or false? It's true. The only way to, well, not the only, because that's not the only part of the treatment plan, but you have to include this in the treatment plan for DIC. You have to resolve the underlying problem, or you could keep giving the patient treatment, but it's not going to fix the problem. So whether the underlying cause is a dead fetus that's in the womb, you're going to have to remove it. Maybe the underlying cause is the preeclampsia or the eclampsia. You're going to have to treat it. Maybe the underlying cause is the ruptured placenta. You're going to have to remove it. Whatever that underlying cause is, part of the management has to include correction of that issue. Okay? All right, select all that applies. What are the expected forms of treatment for DIC? Here are your options. Select all that apply. Volume expansion, rapid replacement of blood products and clotting factors, oxygenation, achievement of normal body temperature, assessment of lab values, administration of vitamin K. What, as a nurse, what do you expect to be included in the treatment for your patient that has DIC? One three nine six two seven. That's the code to get in, guys. Very good, Bakari. Oh, no. Very good, Spitzinger. Sorry. All of them, guys. Besides correcting that underlying cause, we expect for this patient to get volume expansion, rapid replacement of the blood products and the clotting factors, because remember, those clotting factors are being depleted, and that's what's just causing that horrible cycle. Oxygenation, supplemental oxygenation, achievement of normal body temp, assessment of lab values, especially looking at those clotting factors, platelet count, and of course, administration of vitamin K, because again, what has caused this whole thing is the depletion of what? The clotting factors, okay? After trauma, what should you assess first? Should you assess the pregnant patient? Should you assess the fetus? Should you assess yourself? Or you just have no clue? At this point, you're done. Very good. Always, guys. Um, if you have a test question where you have to choose, it's one or the other, every single day of the week it's going to be the pregnant patient care, assessment, resuscitation, stabilization, all of that. Mom first, and then fetus. Who said yourself? One person chose. So you're just going to assess yourself, right? Pregnant mom goes first. Okay, last question. Your patient with cystitis is given Pyridium. What type of drug is this? Is it an antibiotic? Is it an analgesic? Is it an antifungal agent? Or is it an antiviral agent? This is interesting. So 19 of you guys chose the correct answer. This is an analgesic, but another 19 of you chose antibiotic. And here's why I think you chose antibiotic, because you saw that I said your patient has cystitis. What is cystitis? Infection of the bladder, right? And so you're thinking, okay, they got UTI, they're going to get antibiotics. Yes, we do expect that patient to be ordered antibiotics. And when she's pregnant, she's going to get 3 days of antibiotics. But alongside the antibiotics, she's going to get analgesics for the pain. Okay. Something important for you guys to know about this medication, Pyridium, it changes your fluids to a bright orange color. So your urine will turn bright orange. Even your tears will turn bright orange. You have to warn the patient about this or they're going to freak out. If the patient wears contact lenses, you're going to teach them for that short time that they're taking this analgesic, that they need to wear glasses, because guess what? It can even stain the patient's contact lenses. Okay. All right. And that is the last one of the slides. So let's see how you guys did.